Welcome everybody to the first of the Changing Minds lectures. My name is Gwen Adsead and I'm a forensic psychiatrist and psychotherapist, and I'm honoured to be the Gresham Professor of Psychiatry for 2015 and 2016. I had the privilege of giving some lectures last year about violence, which is really arising from half my day job as a forensic psychiatrist. But this next series of 3 lectures is going to be about changing minds. And I really want to start, although they always say you shouldn't start with an apology, I'm going to start with an apology, or really a couple of apologies. The first apology is that the original meaning of apology was about setting out a background for something, an explanation of something. So what I want to do in this lecture is set out a bit of historical background for the whole concept of changing minds. And then the next apology is the more contemporary notion of apology, which is regret. And I'm expressing regret because I know that I'm going to have to deal with some big subjects in a very superficial way. And those of you who have expertise in this area in the audience may well feel shortchanged. But this is really, of course, about the constraints of what you can say in slightly less than an hour. So I'm going to be touching on some big topics lightly, and I hope that you'll forgive me. I want also, just in this slide, to acknowledge some of the people who've really helped me in my thinking around this. Joanna Woodall, who's Professor of Art History at the Courtauld, Professor Barbara Taylor, who wrote a wonderful book called The Last Asylum, which, if you haven't read it, contains a very interesting history of psychiatry and psychiatric treatments. Andrew Scull, who's probably one of the world's best historians, best known historians of psychiatry, and my colleague Maurice Nitzen, who's a psychotherapist and an artist, who very kindly let me use some of his images. So let's start by just thinking about what we mean by change. And the first thing about change is that it involves something about time perception, that there's a difference that happens across time. The much bigger question is what we mean by mind. And I'm going to obviously say a bit more about that later as we go on. I think we need to, when we're thinking about what it means to change your mind, I think it's important to think also about concepts like yourself, your personality, and your identity. To what extent are these concepts, these 4 concepts, are they simultaneous? Are they synonymous with each other? Simultaneous is an interesting slip, actually, in terms of time. Because, of course, we change over time, and yet you retain some sense of who we are over time. And a crucial aspect, of course, of our personalities is that we both stay the same, but we also change. And I'm going to be saying quite a bit more about that in my next lecture. I've been very influenced by Professor Dan McAdam's work on the nature of personality and personality change. He published an excellent book about personality change last year, and he talks about the idea of the way that we might function as both actors and agents and authors, that when we come to make our general decisions, we're actors, but there's a sense in which we're also agents making choices about the types of person we want to be. But then we're also authors of our own self-narrative. And again, that's something that I'm going to come back to, but it's an interesting way of thinking about how your personality and self works. So if we think about some of the early accounts of the self and the mind, you can go back, of course, to the people of the book, to the Abrahamic traditions, and most of these early accounts, particularly go back to what we think of as the axial era, which is 2,000 or 3,000 years before the Christian era. What we find is an exploration, the beginnings of an exploration of self and self-reflection. The idea of the self also being divided into different parts, the heart, the soul, the will. All these things are different aspects of ourselves, which are still very much in play right now in terms of trying to understand how we function. Many of you here will be familiar with classical accounts of self, Plato's accounts of the self in 3 parts. Very interesting if we think, of course, about later about Freudian ideas about the self, also in 3 parts, Freud drawing very much on a classical heritage. The first accounts of mental illness are actually described as early as by Hippocrates and the other writers of his time. And mental illness was understood as a loss of reason, that in order to be a fully functioning person, you had to have reason. And if you lost reason, then you weren't really a person anymore. And that's where these ideas about madness and the stigma of madness really come from, way back to the Hippocratic times. And Hippocrates' model of mental illness was very similar to the model of physical illness that was then available, which was that there was some imbalance of the system regulating how the body and the brain worked. Some of you, again, will know, I'm going to come on and say a little bit more about this, obviously not a contemporary picture, rather a romanticized picture of the classical family getting treatment, but many of you will know that the humoral model of illness, where there's where the body is naturally in some sort of homeostasis, it's naturally regulated, and the body and the mind are linked together by the humours, and illnesses arise when there's disturbance of humoral balance. Which is interestingly much like neurotransmitter theory now in relation to mental illness. Now, in the Hippocratic corpus, they described mental illnesses under categories that psychiatrists still use today, namely mania, delirium, melancholia, anxieties, phobias, puerperal psychosis, and paranoia. These are all diagnostic labels that psychiatrists use now. And I think it's interesting to think about how still quite rudimentary in some ways our understanding is of mental illness. So here's a picture of bloodletting, which was thought to be one of the early ways of restoring balance to a humoral dysregulation. So some of you will probably be familiar with this idea of disturbances of the different types of humours. Black bile, which is where we get our word melancholia from, yellow bile, blood, phlegm, phlegmatic. The word phlegmatic comes from the idea that when you had your disturbance of phlegm, you weren't too disturbed by it. And these are associated very much with physical experience as well. The mind and the body very closely linked together, and that all the interventions, you would change your mind by changing your bodily status, which again in some ways is quite still an active idea contemporaneously. But this model of the mind and its disturbances persisted well into the 17th century and didn't really have any type of significant challenger until there was improvements in neuroanatomy and people started to get really interested in the brain and what it could do. So this is a very important part of understanding, I think, changing minds. And this is the myth of Narcissus. And some of you will, this is Caravaggio, beautiful Caravaggio, and this is Narcissus. And as you know, the sort of overt part of the story of Narcissus is that he fell in love with himself and eventually pined away because he couldn't reach his loved one. But the other aspect of the Narcissus story is that Narcissus failed to recognize himself. That actually Narcissus's problems really arise because he doesn't know who he is, and he doesn't recognize the reflection of himself in the mirror. A key aspect, a key concept, I think, in thinking about changing minds is a very early separation in terms of the philosophy of knowing yourself, which was really, as I say, as thousands of years old, was known, for example, to Buddhist writing, was known to Confucian writing, and indeed is there in the Abrahamic traditions as well, the idea of exploring and understanding yourself. And the myth of Narcissus, of course, is an example of what happens if you don't really know yourself well. But that got very separated from these medical accounts of madness as loss of reason, and the idea of the restoration of reason. You had to behaviorally constrain people who'd lost their reason, because people who'd lost their reason were just like wild animals, so you'd have to constrain them. And that account of psychiatry and mental disturbance was running alongside in parallel these philosophical notions of understanding yourself and how the source of human fruition of knowledge was to understand yourself better. And somehow these two ways of thinking about the mind became completely parallel. And they remain, to some extent, still parallel. And I'll come on to say a bit more about that later on. So because there are parallel types of conceptual thought, what we have here then is two different types of intervention then. So in relation to self-improvement, there was religious belief, and the religious texts and religious practices, faith-based practices, these were often all, and for those of you who are faith practitioners of any sort, this is a live discussion, which is that living a life of faith is about living a better life, about transforming yourself, to understand yourself in relation to your own faith practices. And that, of course, is very much still in relation to religious conversion, anybody who embarks on a professional religious life. This is about the transformation, understanding yourself and transforming yourself. But for mental illness, the treatments, as I said, were mainly associated with humoral regulation. So that went on really until the 17th century. A lot of emphasis on organic causes. And some of you might have seen Dürer's wonderful pictures of the brain, but also some of Aristotle's own drawings of the brain, and the importance of people's understanding that the importance of the brain in relation to mental disturbance. And the first hospitals for mental illness are actually associated with religious foundations in the 14th century. And that's just a picture from, again, I think, the 15th century, just drawing up the different aspects of the mind. So these early modern ideas about the self are that there isn't a single self, that there are different aspects, that we are plural. There's not just one single self that has experiences. There are many accounts of both a sort of inner self and an outer self, but also a lower self and a higher self. So you can find in St. Augustine's Confessions some discussions about different types of self going on, and the struggle that there can be between different types of self-experience. And we find in the 15th century the rise of the portrait, first in sculpture and then later in pictures, where the depiction of a self to other people as virtuous and heroic. So that we're constructing now in portraiture an image of the self that's going to continue over time, even when we've physically gone. But that still doesn't capture that secret sense of self, that notion that there might be a secret self that's not quite what it seems, and it may be hard to know for us to know ourselves, but also might be hard for others to see. And I had to put this one in, of course, because this is a portrait of Sir Thomas Gresham, exemplifying the heroic and virtuous tradition of the portrait, that if you were wealthy, you would commission a portrait of yourself that would really be exemplifying who you were as a good person. And Sir Thomas Gresham was indeed a very good person. But this is a different type of portrait. This is a detail from the Arnolfini wedding. Again, arguably one of the very first portraits painted by Jan van Eyck. I'm sure many of you know and love this picture, as I do. But the nice thing about the Arnolfini wedding is right at the back, you can see the mirror. And in the mirror, you can see Jan van Eyck has drawn a little picture of himself. So his self, his artist self, appears in one of these early portraits. So there's an exploration then to be had, I think, when you're thinking about changing minds. It's an exploration to be had about the self and the person and the identity. So there's a self that speaks and self-reflects and a self that's on show. And but there's a hidden self, perhaps often in terms of desires or thoughts that can't be spoken of. There are persons who typically have rights and duties in terms of both law and moral philosophy. And we often distinguish this notion of your face and your appearance from your heart and your soul. This notion, again, of what's visible and seeable by other people, understandable by other people, but something that's distinct from that secret part of ourselves, as if there's a boundary between different aspects of ourselves. And our identities are arguably a story that we construct over time in the social milieu in which we live. It's a story of ourselves that grows often from our early lives within our families, and then grows to include our friends, our occupations, our hobbies, and then our own families, however they're construed as we grow older. So that story of ourselves across time is perhaps arguably an important aspect of what we think of as identity. It's very much socially located. And this is just another reminder of just how complex and important the portrait and the depiction of yourself has been. This is Maria Antonietta Gonzalez, and she has a hair problem. And so did all her family. It's a rare genetic malformation. But one of the nice things about this picture of Maria Antonietta is that you can see that this is a formal portrait of her. She wasn't hidden away. She wasn't a freak. She was accepted into the court of Mantua, where she and her family were made part of the court. And if you look at her expression, she has a very open and warm expression. And this is something about a young woman who's putting her best foot forward in terms of her image, despite being very unconventional indeed. Oops. I want now just to talk a little bit about Shakespeare. Again, you can see this is why I apologize for touching on some very big issues, because, of course, there's areas of Shakespeare scholarship around the modern sense of identity which take up volumes of work, and I'm going to try and summarize some of these ideas in a few words. But, of course, one of the things that's remarkable about Shakespeare is the idea of a self that speaks and self-reflects in front of an audience. And that really was pioneered by Shakespeare, something about his work that was really quite new. For example, Richard III breaking the fourth wall and talking to the audience directly was quite new and quite unusual. And of course pioneered by Shakespeare, used extensively by Shakespeare, especially for his villains, interestingly. And Lear, of course, as an exploration of changes of identity in different social circumstances and the importance of identity located in your social relationships. Very profound and very delicate and nuanced account of madness in very different ways, where Lear, Poor Tom, and Edgar are all very different types of madness. Something very sophisticated being explored here about identity and what is seen and recognized. And there's a whole essay, or several, to be written about the metaphors of I, the letter I standing for identity, and I, E-Y-E, in terms of sight, the metaphor of sight reflecting identity. Othello, of course, a famous play, again, about madness, madness induced by thoughts, simply by thoughts, which, if you like, is a very cognitive model of madness, not unlike what some psychiatrists use now. And of course that famous line from Macbeth about the mind diseased. So this is really where we get the first mention of a mind that can be diseased, where the mind becomes an object of medical thought. But even here Shakespeare pulls it back and says, not a physician, but a divine, or self-reflection. The way that Lady Macbeth is going to improve her distress is by self-reflection or a divine. So when we get to the 18th century, we now get to some neuroanatomy, and the exploration of neuroanatomy gives some new ideas about how the brain works and how the mind works. But a lot of time is potentially wasted for 150 years or so about the notion of degeneracy, the idea that anybody who's got a disordered mind must have something wrong with them generally. They must be degenerate or flawed in some way. The idea that a normal person might become mad or distressed, it doesn't really figure in these accounts at all. So there's a huge emphasis on the idea of degeneracy and separating out the people who are going to be mad from the people who are fine. At the same time, again, in this parallel track about self-psychology that I've been talking with you about, we have the romantic movements that incredibly emphasize the words to describe self-experience. So the romantic poets and their experience of interacting with nature, these are all about self-experience, and some of them absolutely beautiful. Of course, many of you will be able to quote Wordsworth at me about the notion of self-experience. But all this is a world away from what was happening to you if you were deemed to be mad, in which case you would almost certainly be locked up in a madhouse and held there until something changed. Interestingly too, about this time the portraits stop being so idealized and start to become a little bit more realistic, as if there's a bit more admission of the ordinary self rather than the self on show. And many of you will know this very famous picture. This is of what life was like in St. Mary's Bethlehem, one of the biggest madhouses in England for many, many years. So these were, of course, where psychiatry started, except nobody called themselves a psychiatrist, they called themselves mad doctors, which is rather amusing. The idea was that really you were just constraining people. You were just constraining and detaining people. Interestingly, again, there's a move away from religious context. The very first madhouses had grown up in the shadow, in the environs usually, of religious communities in the context of hospitality and looking after the sick. But in the 18th century, what you saw was a big move away from any link between religious ideas and mental illness. That mental illness was something that afflicted unusual people, and there was something wrong with their brains, and they needed to be looked after well away from nice, ordinary people. Psychiatry doesn't get used as a term until the 19th century. It's only about 120 years old. And that expansion of madhouses to hold people who were seen as mad and different really continued well into the 20th century until suddenly there was really quite a big reversal in the 1960s and 70s. But before that, for 150 years, the main way of treating people who were deemed to be mentally ill had been to put them in a big building away from other people. And that was the mainstay of psychiatric treatment for over 150 years. There was also an important linkage between moral reasoning and madness. So the idea was that people who were mad had lost all reason, and if they did things that were immoral, then that was just a feature of their mental illness. But there was an attempt to try and treat people with mental illnesses more compassionately by helping them, by realizing that not everybody who had lost their reason was violent and inhuman, but if they were treated in humane ways, then actually they could behave quite ordinarily and recover their mental illness, which is a big surprise. In a way, stop treating them so badly and guess what, they get better. But there was very much, again, this is an affliction model. This is not a psychological model. There's no sense that we might understand why these people were so distressed, or why they might be having odd delusions, or why they might be terrified. In this model, we don't try and understand these people's experience at all. We just lock them up, poor things, and wait for it to go away. And that model of mental ill health really persisted for a remarkably long time. And it's remarkable in a way because, it runs in parallel with an increasingly interest in psychology, in how do our minds work, trying to understand how our minds work. And some of you, this is, of course, the inimitable Alison Steadman as Mrs. Bennet in the television version of Pride and Prejudice. And the reason that I put this in is to remind myself to talk about the idea of nerves and sensibility, because this became a type of affliction that more well-to-do people suffered from. And it became a bit of a fashion in the 18th century to be very sensitive and to be very distressed, and that was a sign of how well-to-do and intelligent you were. And it was called the English Malady. It was quite distinct from madness and madhouses, and it was dealt with in a medical manner by people who would prescribe treatments for you. So the women typically would prescribe rest, because too much stimulation or action was bad, whereas men were encouraged to take up various activities, interestingly. But it's the beginning here of something psychological, the idea that your nerves and your feelings might be distressing you. But the split in many ways still continues. So you've got this English malady on the one hand, disorders of the intelligent and the sensitive and quality. You give people diet and exercise and rest. Travel, of course, was the other thing that was often prescribed for people who are in a heightened state of nervousness. Change is as good as a rest. Comes from that sort of time. Whereas people with what we probably think of now as being psychotic illnesses were put in madhouses, subjected to various therapeutic regimes, lots of work, not rest, and routine, and very high moral standards. But again, very secular, nothing religious here, toward the complete move away from any of the reflections about improving yourself that were part of the faith-based discussions. So self-improvement by moral growth becomes completely separated in terms of religion and philosophy. These are completely separate ways to improve yourself. And the idea that people with mental illnesses might be wanting to improve themselves, or they might want to change their minds in much the same way as the people with neurotic illnesses or nerves, that idea really hasn't, still to some extent, it still doesn't have any traction, that there might be more in common, that these things might have more in common than they are different. Here are some of the odder treatments for mental illness. Luckily, we've given up on all of those in psychiatry, but it is remarkable, really, interestingly, how physical they are. A lot of emphasis, again, on physical interventions to change your mind. And there is a continuing acknowledgement that the body and the mind are closely linked, but you can't get at the mind, so you do things to the body. This is William James, and William James is the father of psychology, really. He is probably one of the most important thinkers in psychology, because he is really the person who gave rise to some of the most contemporary ideas that we take for granted now. So, for example, he made a distinction between a public I and a private me. He was really the first person to talk about how most of us have these different ways of thinking about ourselves. And he was one of the first people to give a real account of the self as a being that has agency, that makes choices, and makes choices that have meaning for that personal self. And he also, interestingly, put together three aspects, again with that number 3 again, a spiritual, social, and a bodily aspect of the self. So he's emphasizing again the bodily aspect. But he also wanted to think of the spiritual self as being the core of who we are, and that your spiritual self could itself become sick in some way. Notice again the use of the word sick, so we have here again a medical analogy coming in here. But both your I and your me could be disturbed or disharmonious in some way. So what emerges now, interestingly in both psychology but also to some extent in philosophy, is something about phenomenology, describing what mental phenomena are like. And it's really remarkable that it's taken us so long as human beings to really get down to a type of scientific methodological study of what goes on in our minds. But what goes on in our minds had previously been beautifully described by poets and dramatists, and of course to some extent, as in interior reflections like confessions or diaries, indeed the novel. But in terms of the scientific study of the mind, really starts with philosophers, in fact, about describing different types of mental phenomena. And so psychiatrists start to become psychologists as well. So they're not only just thinking of somebody as being ill, but they're looking at their psychology and trying to work out what's normal for them and what's abnormal for them. So this is something so that your distress and your disturbance could be quite separate from any lack of reason that you have. And this is a portrait by Géricault, actually done, who was, some of you will know, is a famous French painter. He was advised, he suffered from mental illness, and he was advised by his psychiatrist to take up painting. So he painted some of his fellow patients in the psychiatric hospital where he was resident, and this is a portrait of a monomaniac. Monomania was a very popular diagnosis, which was about people who fixated on one idea. And again, I'm sure you'd agree this is a very sensitive type of portrait. You'll notice that the gentleman has two very different eyes. A really big change to the history of changing your mind comes really with the First World War. Because with the First World War comes two things. One is the application of psychiatric and psychological ideas as a science to what was seen when people came back from the war. But it was also clear from the war, from the effects of the American Civil War first, but then the 1914-18 war, is that the theory of degeneracy just wasn't going to hold any water. The idea that the people who had become mentally ill were somehow flawed, were bound to get these things, had some sort of degenerate strain in their genes or their blood or whatever it happened to be, it was clear that that simply wasn't true. As thousands of perfectly healthy and resilient and brave young men came back in huge distress, and often with their minds broken, if only temporarily. So they then developed a real interest in how is it that environmental stressors could change your mind so much that you would become distressed. And psychological experience started to become better understood as a key feature of mental health. But there is still a tension here between the idea of some sort of brain disease. So some of you will know that the earliest accounts of shell shock were suggesting that the brain had been affected by the impact of shells, not actually hitting someone directly, but actually just the concussion effects of shells going off. But that organic model is set against a type of psychological model of odd thoughts that make you distressed. This is Magritte's picture of a therapist, and I must say I think it's very lifelike. When I think of the therapists I know, that's a very reasonable depiction of the therapists I know, including myself. So what we find now in the 20th century is lots of different ways of changing your mind. So of course we see the beginnings of the psychoanalytic movement and the idea of the mind that isn't conscious. So now we have the secret self is located in the unconscious mind, and that the work of changing your mind is about making the unconscious conscious, and that making things that are implicit and secret more open. So again, we're back really to classical ideas about knowing yourself. Freud, hugely influenced by classical writers. So there's a knowing yourself, but there's also the idea that you need a skilled physician to help you to do that. You need another person there to help you. Drug treatments, of course, come in the 1950s, and that really, of course, takes everything back to a type of humoral model, that the cause of mental illness is disturbances of neurotransmitters. If we restore the balance of the neurotransmitters, then mental health will be restored. Now, this has worked quite well to some degree in certain circumstances, but in other ways doesn't work very well at all. But there's no question that it does work for some types of mental disturbance, and that's, in a way, an interesting idea. 1950 sees the rise and fall of brain surgery for mental distress. There have only been 2 Nobel Prizes awarded for psychiatry, and one of them went to the pioneers of leucotomy. So even the Nobel Committee gets it wrong sometimes. So in the 1960s, we see the development of cognitive therapies and a challenge to psychoanalysis in terms of the unconscious mind is not all there is. The unconscious mind and our unconscious processing is undoubtedly important. It's no secret that there's aspects of our mind that we're not conscious of. There's a huge amount of mental processing that we're not conscious of, particularly in relation to our bodies, of course. But a lot of people felt that the emphasis on psychoanalysis had really meant that the conscious mind, the conscious experience of thinking and feeling, had got a bit left out. And the work of Aaron Beck and subsequent cognitive psychologists has really led to a cognitive revolution in taking thinking seriously. But it still leaves us with a question about what's changing. When things change in your mind, when you go for therapy, and if your therapy works well, what is it that changes? Is it an external change in how you relate to other people? Is it an internal change in the way you think about yourself? Or possibly both these things? And which one would you like to aim for when you start your therapy, and who gets to decide? This is one of Maurice Nitson's wonderful portraits. It's called Man in Thought. It's a beautiful example of how ideas about portraiture have changed, that now we no longer need a perfect realistic depiction of a human form to give us a sense of who a person's self is. Here, Maurice uses colour and the thickness of paint and different types of proportions to give us a sense of what this man in thought is thinking. And we can all speculate about what this man in thought is thinking. But it's a different approach to the portrait. The other important aspect of the 20th century is our understanding of ourselves as social. That although that sense of yourself as being located about an inch behind the bridge of your nose is a very powerful experience, Nevertheless, there's a very important part of yourself which is extended outside your body and located in your social relationships. So if you think about your social identity in terms of the way you occupy your time during the day, so your identity is as a child of your parents, as a friend of your school friends, as a student, as a practitioner of whatever job you do, as a hobbyist, and you may be known in very different ways and held in yourself in those different social structures, may be subtly different from the way you are in other social structures. And there's been a huge emphasis on looking at social relationships and its effect on self-presentation. And some of you will know the famous work of Ernst Goffman in terms of the presentation of self in everyday life, and the idea that we are, as it were, on a social stage a lot of the time, presenting the way that we want to be, whereas some parts of ourselves may be hidden. So again, we come back to that theme about the self that's visible and the self that's not seen. And when you go into therapy, what is it that's changing? What is it that you want to change? How do we improve ourselves, if improvement is what we want? Because, of course, change doesn't necessarily imply improvement. It could just mean something is different. Obviously, a lot of post-war studies of people who survived the Nazi occupation, and particularly the Holocaust. So the first, again, in detailed examination of what happens to people's minds in extreme social situations. And an emerging criticism, particularly in the post-war civil liberties period, an emerging criticism of traditional models of medicine being applied to mental health, because medicine had excluded the subjective. Because when you go to see your doctor with your appendicitis, what you feel about yourself is not terribly important to whether your appendix bursts or not and whether you need surgery. But when it comes to your mental illness and your psychology of yourself, then what your subjective experience is going to be hugely important, and maybe hugely important in the way that you talk to your doctor and to your therapist. So over the last 25, 30 years in particular, there's been a huge rise in the study of personality and personality change. We know that our personalities are combined of both fixed elements but changeable elements. We know that our genes are quite important to some aspects of how our personality works, but also our social environments affect how our personality works. I've already talked about Dan McAdams, and I want to emphasize this notion that McAdams has about the narrative self, the story you tell of yourself across time. And I think that's very important in terms of when people go into therapy and seeking change. It's often something about the story of themselves that they're not happy with. They're not happy with the story of themselves. So now we have the self as an object of treatment as opposed to a disordered mind. I think often, if you think of the huge explosion of therapies that there are available, many of them focus on people's experience of themselves, where your subjectivity, your account of yourself is dominant. And this is a challenge to the idea that you'll go and see somebody who'll tell you how your mind should work. And a lot of reaction to some of the more controlling and restrictive aspects that there have been in psychiatry. It influences political movements because it saves money in healthcare and promotes normalization. And so saving money and getting people out of institutions, getting people more sense of agency over their minds has been absolutely crucial in terms of understanding mental distress. So again, we've seen this rise of psychological therapies and the concept of self-improvement through psychological exploration. So the self becomes a person who's located in a relational context, as well as being an individual. So we no longer just think of ourselves as an I, we think of ourselves in terms of the relationships that we're in. And of course, there's been a huge expansion, particularly over the last 100 years, of therapies for relationships, whether it's relationships with partners, relationships with children, relationship with parents, relationship with people at work. A new focus, really, particularly in the last 50 years, on therapy for relationships. And I'm going to close with just a couple more slides to think about, just to mention mindfulness practice. And this is a nice slide just showing a combination of the idea of changing your brain and also changing your mind. So here, this is from a study which is looking at how your changes in amygdala function with mindfulness practice. And in this particular study, the authors found that there was a decrease in amygdala activation with regular mindfulness practice. And as many of you will know, the amygdala is a part of the brain that is very important in regulating fear and anger responses and just general getting uptight responses. So regulating the amygdala for people who've got anger problems might be quite useful. And in this particular study, mindfulness seemed to be helpful. But I put it up there not really to convince you of anything in particular, except to say that this is a nice example of where attention to the brain and attention to the mind meet in a type of research study. So now I think we are still struggling, with a bit of a tension between mental distress that's arising from personal experience as a self, what your self experiences. I'm distressed because of this, that, and the other, or I think I need help to understand myself better because of things going on at work or things going on with my partner, or whatever happens to be. But also then this parallel account, well, you are also a bundle of neural circuits and neurotransmitters and genes that affect how those neurotransmitters are processed, and we need to understand that as well if we're trying to understand who you are as a person. So we encourage self-exploration and introspection, and that's very interesting because we've come literally to where we were 2,000 or 3,000 years ago in terms of taking our self-experience, trying to deepen our understanding of who we are in the present moment. Present moment attention is something that we know is of enormous interest right now, but we're really picking up where Buddhist writings and some of the medieval contemplative traditions left off. I think we still have a split between psychology and psychiatry, sadly. It's very difficult if you develop a mental illness. Getting some psychological help to understand your predicament is very difficult and been made much worse over the last 5 years because of cuts to services. But I think it would be fair to say that we still have some uncertainty, perhaps lots of uncertainty about the relationship between these different aspects of who we are as people. The relationship between the self, the person, the identity, your will, and your heart, in the metaphorical sense. That our understanding of these different aspects of ourselves is still at its most rudimentary, and still, therefore, all to play for in terms not only of research but also of general understanding. And I'm going to finish with this, closing with another man in thought by my friend Maurice Nitzan, and again express my gratitude to him for letting me use this slide. So, I'm going to close there, and we have, in fact, about 15 minutes for questions or comments. So, thank you.